Hello everyone and welcome to my YouTube channel. So the topic that I'll be briefing today is atrial flutter. So atrial flutter is characterized by a single large macro re-entry circuit within the right atrium encircling the tricuspid annulus, and the atrial rate is about 300 beats per minute, and it should always be suspected when there is a narrow complex tachycardia of 150 beats per minute. It is associated with Wenckebach's phenomena, that is type 1 morbid type 1 second degree AV block. So it is usually asymptomatic, but patient can present with palpitations, syncope, lightheadedness, dizziness, shortness of breath, trouble with normal activities or exercise, and tightness in their chest. Carotid sinus pressure increases the degree of AV block and reveals flutter waves. Intravenous adenosine increases the degree of AV block and reveals flutter waves. So basically, if you are giving a carotid sinus massage or if you are giving IV adenosine, they will increase the degree of AV block and they will reveal you the flutter waves on the ECG. ECG shows regular rhythm unlike atrial fibrillation, because in atrial fibrillation the rhythm is irregular and there will be a saw-toothed flutter waves in especially lead 2, 3 and AVF, which are the inferior leads. See, this atrial flutter waves have saw-toothed appearance. The treatment goal for symptomatic atrial flutter are similar to those of the atrial fibrillation, and they will include control of the ventricular rate, restoration of the sinus rhythm, prevention of recurrent episodes or reduction of their frequency or duration, prevention of thromboembolic complications, and minimization of adverse effects from the therapy. So the main difference between the treatment of atrial fibrillation and atrial flutter is that most cases of atrial flutter can be cured with radiofrequency ablation of that re-entry circuit. So why there is need to give long-term anticoagulation and antiarrhythmic medications when you can treat it with a simple procedure, and it has high success rate and low complication rate as well, therefore it is superior to medical therapy. So we should consider catheter based ablation as first line therapy in patients with typical atrial flutter if they are reasonable candidate. However, anticoagulation may require if the patient has atrial fibrillation as well because of the formation of thrombus and embolus. Ablation is usually performed as an elective procedure, however it can be done when the patient is in atrial flutter as well. So for hemodynamically unstable patient, whether it is atrial fibrillation or atrial flutter, we have to perform immediate electrical cardioversion to sinus rhythm. However, for hemodynamically stable patients, medical management can be done for rate control and rhythm control. So the step 1 is rate control. The target rate should be kept 60 to 100 beats per minute, and the agents that can be used to control this rate are beta blocker, which are the preferred agent, calcium channel blocker, example verapamil, diltiazem and digoxin. This is Chadwick's score, and it should be performed for starting anticoagulation therapy, and they will tell you that whether the patient needs anticoagulation or not. It is used for atrial flutter as well as atrial fibrillation. So you can see C for congestive heart failure, H for hypertension, A for age more than or equal to 75 years, diabetes mellitus, previous stroke, vascular disease, age of 65 to 74 years, and sex category is female, and each is giving 1 point except for age and stroke. So if the score is 0, then aspirin only is enough. However, score 1 requires anticoagulation with warfarin or aspirin, and a score of 2 or more must require warfarin. So the rhythm control is a step 2, and if atrial flutter is less than 48 hours, that is acute onset and low risk of a stroke using Chadwick score, then IV heparin is given followed by cardioversion. Electrical cardioversion is preferred over pharmacological cardioversion, and electrical cardioversion is also called DC cardioversion. Pharmacological cardioversion can be done by using parenteral flecainide and procainamide and amiodarone. These all are antiarrhythmic drugs. So if it's been more than 48 hours for atrial fibrillation and there is high risk of a stroke using CHA2DS2VASc score, so we can follow any of the two following options. So the option 1 include that we will anticoagulate 3 weeks before cardioversion, then we will do cardioversion, and then we will do 4 weeks anticoagulation after performing cardioversion. And the anticoagulation is usually done with warfarin, and target INR should be kept between 2 to 3. So in option 2 we will skip the 3 weeks anticoagulation and we will go for transesophageal echocardiogram to look for left atrial thrombus. If the thrombus is present, then we will follow the option 1, that is anticoagulation for 3 weeks and cardioversion, then post cardioversion anticoagulation for 4 weeks. But if the atrium thrombus is absent, then we will directly perform cardioversion without any anticoagulation. That's it. That's the end of the lecture. I hope you learned something from it. If you do, please like my video and subscribe to my YouTube channel. Thank you so much for